First technique we'll look at will be stress testing, as we did in the rest of the spine. And testing here is a little more difficult than testing in the craniovertebral joints and the cervical joints, again because of the stability. So we'll be tending to use the arms, and the fixation will be done with the back of the hand, or with the hand at the back. And you're going to have to be very sensitive about feeling for excessive movement. So we'll check posterior stability first. And in order to do this, I want to stabilize the lower vertebra of the segment we're testing. So I'll work down the spine from C7 to about T3 or T4, stabilizing the inferior vertebra while I palpate the superior vertebra. Now, in order to do these techniques, the hand position is important, but just as important is the patient position. And we'll need to get the patient very close to you. Move across towards me, Beverly, so that your bodies are actually in contact. And this way you can use your body to produce a movement. The patient's arms need to go on the back of their neck, so they interlock their finger, and this will help stabilize the rest of the cervical spine from any stresses that are induced in it. And we'll lock a finger somewhere around about C6 or 7. Now, we'll palpate about T1, and then I'm going to shear back. I've got my index finger, my middle finger and so forth on the spinous process, and my index finger will be palpating C7. And I will shear back through the arms now, like so, and I'll be palpating for movement of the superior vertebra, and just moving down onto the next and doing the same thing. And we're feeling for any movement that may occur. And there's some resilience that you can palpate through the arms, but there should be no actual slippage of the superior vertebra. Thank you. The next test we can do in sitting will be traction. And this one is a general traction, and you can do it for the whole thoracic spine or simply for this region. Now, the traction again can be produced through the neck as a general stress from the occiput up through the rest of the spine. But again, I'm going to assume that the cervical spine is a problem, and we'll do it through the arms again. Now, I'm not going to fix any other part of the thoracic spine, and this will be a general test for the whole spine. And if you're reproducing pain, the area that the pain is being reproduced in will give you an indication of where the instability or problem lies. Now, it's important that when we do this technique, again, that we have good contact with the patient, and we need the patient sitting way back on the bed for this. Keep coming. So they're right on the back edge of the bed. And again, position yourself so you stop them falling off. And bring the bed up slightly. And now for this technique, we'll have the patient cross their arms in front of them this way. Try and keep the arms parallel rather than crossed over, so that this isn't happening. There's a loss of stability when this occurs, so bring the arms parallel with each other. You will then grasp the lower elbow, like so, and just pull the patient back on you and get them to relax. So you have to let their head go, and your arms will be tucked underneath the scapulae. We can then simply lean back away from the bed and allow body weight to produce the traction. Like so. And this isn't an end-fill technique. We're looking for a reproduction of pain rather than any end-fill. It's a little bit incredible to think of end-fill when you're testing so many segments out, and it's impossible to do specific traction at each segment. So it's a general traction test. Similarly with compression, we can go through the neck if the neck isn't a problem, like so. Or we can simply go through the shoulders again and apply a prolonged stress into compression in that manner. Having done the posterior stress test and the vertical stress test, we can start looking at anterior stress testing. Now, the reason I've left anterior till last is because there is no fixation with the anterior test. And if we push forward, say on T3, we really don't know whether, and it's a positive test, we really don't know whether it's positive for a posterior instability at T2-3 or an anterior instability at T3-4. So having ruled out the presence of a posterior instability, any positive stress with this will have to be for an anterior instability. For this, we need the patient in prone lying. Head this end for me. And we'll apply pressure to the transverse processes rather than the spinous processes, and this will ensure that we actually get a direct anterior shear rather than a tipping of the vertebra. So just come slightly out from the spinous processes and push down. You can use your thumbs this way, or equally as well, you can simply lay your finger on each side of the transverse process like that and push down through your hand in this manner, and this is actually a little less traumatic for your thumbs and for your fingers. Thank you. So we should have an indication of whether or not we have an anterior, a posterior or a vertical instability from these tests. Of course, the reproduction of pain itself does not imply that there is instability. We're obviously stressing the joints, and if we have any sort of capsular problem, then this will be positive for pain. Again, for an instability, we really need to feel, particularly in the anterior posterior stresses, actual movement occurring. Having satisfied ourselves that there is no instability there, though, the next problem we have to address is mobility.